Excellent. Welcome to another week of Virtual Global Spine. I'm Matthew Goodwin from Washington University in St. Louis. Um, Sorry for the little delay there. My computer froze. So we are going to. Someone's AI bot is taking it. It's got it. Okay. We're going to talk about a case, an en bloc spondylectomy from actually a couple years ago that is ongoing, and we're just kind of going to go through it. And I guess we're going to pick this out in the show tonight just because I recently was talking about it somewhere, and it kind of reminded me of the many things that I had not experienced before that I did during this case. And my disclosures. So we know that an en bloc resection for a primary tumor is as really as good as you can do for treating someone with a primary tumor, meaning if they can get an en bloc resection, en bloc spondylectomy, and it's a primary tumor and you can get it out en bloc with clean margins, then they're going to do much better long term in terms of local recurrence, in terms of survival. And we've even looked at things like quality of life long term, and they do quite well. In fact, when you talk about complications, which is always what you have to think about in these cases, one of the worst complications when you look at some of these studies is having a local recurrence. And so you always have to be ready for complications if you're going to do these surgeries. I always tell patients if they're going to have an en bloc spondylectomy, sacrectomy, something like that, that there's a 100% chance of a complication. It's just a matter of which ones and how we're going to deal with them and how major they are and that sort of thing. And so Sorry, my computer's being a little funny right now. And so I'm going to show you a case where we are going to have a list of complications that I did not think it was possible for one human to undergo. And so here's just a quick list of things this patient undergoes during this course, and it's really crazy. I mean, he's really a remarkable guy, and when we look at some of the things that have happened to him, it's remarkable. And so where did all this start? Starting 2020. He's a 44-year-old gentleman, healthy, 6'2", 260, and he's got an L2 biopsy-proven chordoma, which you can see here. And at that point, we worked him up and did everything, and the plan was for a back front en bloc resection with adjuvant radiation therapy to the field afterwards. So here's stage one. We get our screws in there above and below. We take off the posterior elements en bloc like you see here. That all went well for the first part of the surgery. And then intraoperatively out of nowhere, he had a drop in his blood pressure. In fact, his maps were into the 20s and 30s for about 5 minutes. And anesthesia couldn't get him back up. They had to start epinephrine. Never lost a pulse. Did have to feel for his pulse, and he maintained it. But we had to quickly staple him up, abort the procedure, and flip him off onto the stretcher to keep him alive. Once we flipped him, he started doing a little better, but still pretty unstable. And got him, never had to start compressions, started to get his maps up with the epinephrine, and then got him up to the ICU and over to the scanner. And so, kind of the first thing that came up, and this was early in my career, 2020. I started at WashU in 2019. And so, the first thing is, what do you tell the family at this point when you're going down to when the patient's going to the ICU and you're not really sure what's wrong? Or if they're going to live, or if they live, what their brain's going to be like, or how they're going to be doing. And so, at this point, I went down, and his wife was down there, and I think everyone on this call is well versed in talking to patients after surgery, so I won't belabor the point, but I try to talk to every family in person after every surgery whenever possible. I'm still to this day amazed at how much families appreciate that and seem to like that. And as many of you do the same thing, I try to lead with when surgery's gone. Well, I try to lead right away with, everything's gone well. He or she's doing fine. And then I go into the details, kind of tell them what we did and whatever. Um, and when there's a complication, I try to lead as succinctly and clearly as I can with what exactly is happening. And so, in this case, I said we had to stop the surgery early. Your husband's alive. He's in the ICU. We never had to do chest compressions or anything like that, but he did have low pressure, and that's why we had to stop the surgery. And right now, we're trying to sort out, what happened and why that is. And I told her, I said, I suspect a clot in his chest based on just how he acted physiologically. Um, but we don't know yet what it is, what happened. We're still trying to sort that out. And this patient's wife is just a remarkable lady, and she just kind of calmly took it all in. And I said, "Is there anything else I can tell you or questions I can answer?" And she just calmly said, "Thank you for letting me know. I'm going to go to the cafeteria, have a cup of tea, and collect my thoughts," or something very calm. Something very calm. Where I thought, think she has better bedside manner than I do. I mean, she's very, composed about it all. And so, nonetheless, we take him to the scanner after this, and he's got these bilateral lobar PEs. Goes on anticoagulation, and we eventually end up. He does actually well. Ends up waking up. He's intact, and the maps didn't seem to hurt anything brain wise or anything else. But you really want to go back to the OR soon because he's got a tumor and he's got a spine that is going to start to scar in, actually, unless you can get back to it. So he gets an IVC filter, and we went back about a week later. And here you can see some of the surgical steps. So that you can see us there in the center looking at the L2 roots. And if you notice off to the right here, the L2 root was going right into the tumor. So those got sacrificed bilaterally. And then we put a celastic sheath between the thecal sac and the vertebral body, so we could come back in the front to remove it. And we also had a small defect in the dura around there when we were doing this, and we put a stitch in that and repaired it, and that seemed to do fine. Came back a few days later with stage 2 and completed the en bloc surgery. And so here's the rest of the vertebral body. Ended up having negative margins. Things were successful at this point. Did our reconstruction. We did a vascularized autograft fibula here, and put it inside of a cage. And that was kind of a variation of what Schwab had described in his paper on putting vascular grafts inside of allografts. We just thought this would be stable as well. And so here's our construct at the end of the day with our vascularized graft spanning from L1 to L3. This all went really well and smooth at this point. So, however, post-op day 1, his right foot gets cold that evening, dusky. He actually really hard to Doppler pulse. Feels like we still have one, but it's very, very faint. And ends up getting scanned, and he's got large clots up and down, actually both legs below the IVC. And so it's just worse on one side. And so he actually gets taken for an emergent thrombectomy, which I at that point really hadn't seen him do in the legs like this. And the vascular surgeon took this picture because said it was the most thrombectomy they've taken out of a leg in a situation like this. So just clotted off all below the filter. So at this point, obviously, the filter ends up coming out. He actually does well post-operatively. He's intact and he's ambulating. He's there for, I can't remember exactly, maybe 10 more days, something like that. And when he stands up to get his standing films, I see him leaning here, that panel on the left, and I have a lot of concern for his stability. And I think I should have gone longer than I did here. He was young and he's pretty strong, and so I think there was some thinking on my part that we try to preserve those lower discs there and make this real sturdy. But when I saw him kind of lean like that, standing up, I talked to him about how destabilizing these surgeries are, and I had a lot of concern for how this would last. And the patient at that point after having gone through all that with the PEs and the leg stuff, just said like, I hear you, but I feel pretty good when I stand up. I'm really tired of being in the hospital. I want to just go home and like we're gonna come back, but I want to just go home and like see my family and spend time outside of this place. And um, he's a normal dude, and I kind of had to say like, got it, man. I hear you. Like that sounds fine. And so, but importantly, we'd had that conversation because I was pretty worried about this kind of long term. And so we agreed to let him go. Close follow up. Um, and he did. In fact, this standing film here, I don't have the dates in here, I guess, but this was actually after, I believe, a year of follow up. So he actually, as he kind of got stronger and recovered, he was doing better, and his films looked better and better every time I saw him. I think on account of just being young and strong and in shape. But certainly don't. I guess what I'd say and what I've learned is you just can't underestimate how destabilizing it is when you take everything around a segment of the spine, right? So these aren't just corpectomies; they're circumferential resections, and they're just really, really destabilizing. So at this point, he gets it on block. He gets the cancer removed. He undergoes radiation and he's ambulatory. So he's had it on block. He's had the tumor taken out, but at what cost? And so I presented this earlier in my career, kind of talking about the cost of an on block, and the things that can go wrong and that sort of thing. And so negative margins, ambulating well, but it's you took a bone from his leg, you sacrificed some roots, had life-threatening PEs, had limb-threatening DVTs, and I guess the thing I haven't talked about yet is that I think once or twice in the process of all that, we went back to wash out the incision because it didn't look good and grew Pseudomonas out of a couple of those. So he's on antibiotics now, long term as well. But wait, there's more. So certainly that was stuff we talked about for a while, but there's always follow up. And so he is, like I said, he's intact and he's ambulating, he's doing better. But about a year and a half out, he develops pars fractures. And so here you can see about a year and a half out, he comes in, he says he's got new back pain. It kind of came out of nowhere. He's not a complainer. And sure enough, on the CT, he developed these pars fractures right below the construct. And so, kind of what you might expect could be a complication of this, and exactly what we talked about is how much stress was down there. So at this point, we decided to revise him. He was getting worse and worse pain wise. Like I said, it was bilateral fractures, pretty unstable. And of course, his filter was out at this point, and vascular said we obviously can't put it back in. Look at how he clotted off his legs. And so we had a plan made of how we were going to do the pre and post anticoagulation, and he did great. He kind of rolled through the surgery, um, no problems. Went home early, happy, intact, etc. And in fact, he does well for about 3 years. But what happens in those 3 years? Well, a couple minor things that maybe were not minor. So one is he stopped his antibiotic suppression. I think I'd wanted him to stay on it forever just because the metal and the infection. And I believe he had some GI stuff with it, didn't like how it made him feel, and just kind of stopped taking it and went on for years being fine. And that's a whole nother discussion about uh, how long you need to stay on it. Do you need to be suppressed forever, etc. And oddly enough, he developed a single solitary lesion in his heart that got resected with the cardiothoracic team. That was chordoma, and so he never had any local spine recurrence at this area. We had good margins on our specimen, but he had this bizarre thing in his heart. So chalk it up for another kind of weird thing with chordoma. So he's doing fine after that. In fact, he's doing well, and then he comes back last year after feeling a pop in his back, and he's got a broken rod, which you can see here. And so we talked about this. When you look at his vascular grafts in there, they looked pretty good, but not big and robust. And in fact, I would guess that through all the complications he had afterwards, that I imagine the vascular supply could have been disrupted, but it wasn't the big robust fusion you see in a lot of these vascular grafts. And so, um, He felt the pop. He had pain that was getting worse. We tried to treat it non-operatively. Like I said, he's a pretty normal guy, and so we kind of talked about the risk that he was to go to an operating room. And but his pain kept getting worse and worse. And so we talked about kind of what the options were, and he eventually said, if you can open up and replace the rods, that's what I'd prefer, rather than let the pain get worse and have that cage move or crack whatever little bones fused in the front. And so we talked about revising it, and the things we talked about for the things we considered before revising were things like if you look at his MRIs over the last 2 years, you could see that there was this fluid collection that had been called seroma. It had been the same for over a year, and it just kind of been sitting there. But thankfully, one of the things we talked about beforehand was whether this was seroma, whether this was CSF and a little pseudomeningocele, or what it was. And we also talked about his clotting history and the fact that we can't do an IVC filter, so we'd have to do the same thing we did the time before, which is, kind of pre and post anticoagulation. And he said, I understand that. I understand this is sitting in whatever this is, but, probably makes sense to replace the rods. And so that's what we did. So January of this year, we took them and revised them. And in this case, we replaced the rods, of course, and we used an allograft strut graft. And so, and then then when we opened up, we sent fluid, that seroma or whatever it was, which came back as CSF. And as we peeled back some scar, we actually found a defect in the dura and then repaired that. And here you can see our allograft strut. And these are something that we've had actually a lot of success with over the years. When I was in training with Dan Shubin, we did some of these. We would often talk about how they probably won't fuse, particularly in radiated tissue, particularly with a dead piece of bone. But we've had more and more people over time end up fusing these. And part of that might be well, there's a lot of things that probably go into it. I mean, certainly having younger patients with primary tumors, I think likely helps that. But you can see that we try to get graft all around it when we do it. We try to, I'll actually shave the bone so it fits right where I want it to fit. My goal is typically to have it fit so that if I didn't tie it down, it wouldn't move. And so you can actually see the holes here, and right here, where I've drilled holes that go through the graft and the spinous process, and then I tie it with a fiber wire to lock it in place both places. You can also see how we shape it to the spine here. You don't want this thing sticking out into the skin or anything like that. And so we've used this a lot of times. Here was another primary tumor in a young patient, which we had good follow up on, and this is kind of what they end up bridging many times when we don't expect them to, and kind of growing into the bone above and below, and are quite robust. So here's a picture of what it looks intraoperatively. Um, like I said, I drill through both sides of it, drill through the spinous process, and then use a number 5 fiber wire. This is a suture that's used a lot, or used to be used a lot in shoulder surgeries. And I don't think you can break it by pulling on it. It's just remarkably strong. And then I'll loop it around both rods. This is something I learned from Dan Shuba when I was at Hopkins with him, and loop it through the graft and the spinous process with like a Houston passer, and then come back and tie it over the top, one up top and one down here. And again, when I do this, try to shave it and fit it so that when you push it in here, it's really not going to move anyway. So these are really kind of belt and suspenders, extra ties here, because you want it to sit in place and have a chance to get some ingrowth if that's at all possible. So we do that with our patient January 5th. We also sent that solution for culture, even though it didn't look bad, and came back with Pseudomonas, which was not terribly surprising because he'd stopped his suppressive medication, and we thought that might still be the case. Post-operatively, he has postural headaches, and they continue. And post-op day 3 now, he still has them. He can't sit up. He gets a headache, and so we go back, or we get a lumbar drain placed on the 9th, but his headaches continue. They start to get a little better, but then on the 23rd, he starts getting fevers. He's got a culture from his lumbar drain that somebody took showing Pseudomonas. Unclear if that was contaminant, given that he's had Pseudomonas, or if it was real. But nonetheless, with the fevers and the concern for meningitis, we took him back to the OR to revise the durotomy and with a fascial patch. And unfortunately, the next morning, even though he was supposed to be flat to allow that to take, he was tilted up at 30 degrees and um, wasn't real happy to see that right away after repairing this dura that was all radiated and scarred. And the well-meaning nurse said, "But the bed is flat. We just tilted it up." And nonetheless, headaches continue after that, and so neurosurgery placed an EVD. Ends up the EVD is not working too well over the next couple days. Finally, we decide that we're returning to the OR, and then we're going to go. Neurosurgery is going to come, plastics is going to come, and we're going to do a like a TFL patch and really do peel off more scar, make sure we can see everything that's leaking, and then put a flap on top to fill the dead space, and so that if there is any leak, it's not going to get out more. And so intraoperatively, I think we have to add them on after clinic, if I recall. So we explore the dura, we do the TFL patch, gets a lumbar drain, the EVD stays in place. And at this point, it's getting late. We turn the case over to our plastics colleagues for the latissimus flap, and they start working on that. And that goes really well. They do a beautiful job. They get the flap over on top of our repair. Everything looks really nice. And I'm at this point now going home, and I'm in bed, and I get a call from my resident at about 4 a.m. And the call from my resident is that at the end of the case, the patient desaturated. She called from the OR and said he's been desaturating for about 30 minutes to around 30 to 40. And basically saying he's about dead, and says we've made the decision to get, excuse me, emergent ECMO. So she said the plastic surgeon said you're now with the ECMO team. They're doing emergent ECMO to keep him alive. And of course, this is a startling way to wake up. So I come in, and that's what's going on. They don't lose a pulse, but they do say they're not sure why they can't get his saturation up. He looks terrible. His heart's still beating, and they get the ECMO in. Of course, he then has a massive desaturation event even when he's on ECMO. Find out there's a huge clot in the machine. And so now they get that cleared, and now we're on our way to the cardiac ICU. And so what are we going to do now? So he didn't get compressions. His heart's working at this point, or was. He remains alive. But he's had 30 minutes of being desaturated to like 30 to 40%, which is not super compatible with life. And so family's out in the waiting room. And at this point, what do you go tell them? And so, I think like any complication or any problem, you tell them the truth about what's going on and try to give them the best update you can. And so they, of course, had been updated by my colleague because she had called, my plastic surgery colleague had called and said, "Look, here's what's going on. You guys tell me if you want this, but I'm calling for ECMO to keep him alive, essentially, or try to keep him alive." And they said, "Yes, please do." And so they already were briefed as to kind of the dire situation we were in. And so I went and talked to them, and I kind of broke down and started crying with them, which I haven't done with a family before. And it was more just because I was sad. It was just kind of crazy. This guy had been through so much. We were just replacing rods, and now he's had this complete catastrophe happen to him. And the family was, I think the wife was consoling me, and it was just a really bad situation. So tell him everything that's going on and tell him what we're going to do. He's going to have to get his chest scanned, of course. We all think about clots, um, and he'll be, he's going to be on ECMO, and we'll kind of go from there, see what we can find out. They're fully aware that his brain might not be normal if he does, kind of come around or wake up. And so now at this point, it's 7 o'clock in the morning, and my elective case should be starting, right? And so I have a revision T10 of pelvis on for surgery. And so what do you do? Do you do the case? Do you cancel the case? I actually thought at this point, um, I think I thought, well, it's like any other job, right? Like it's the case is there, the work is there. We'll go do the case. But I think you kind of forget that you sometimes that you don't work in a vacuum, and you're a human, and you work with other humans that have all been dealing with this and seeing this go on. And so three or four people said, are you going to do are you going to do your elective case? And and uh, and I said, well, I think the first one or two people said, I think so. Like I was really stinking sad, but I'm also, I'm also, it's also my job, and I'm a worker bee, and so, but my PA, who I know very well, I've had her for many years, kind of said, you think you should do the next case? And I said, well, I don't know. I said, I feel fine. I said, but how about we just go talk to the patient that's on for the next case? And and I was like, I'll just tell her what we just did and kind of let her have the choice, right? If she feels uncomfortable with that, or she wasn't it wasn't like a terrible radic or a cancer thing. It was an elective uh, T10 to pelvis revision, that needed to be done, but you could delay. And so I went and talked to her about what she wanted to do, and I had known her for a while. Actually, that patient fantastic, and she said, "Why don't we just delay it?" She was like, 'cause I kind of told her what we did. I said, "Well, it won't affect me doing surgery." I said, they may call from cardiac ICU to update me or tell me what's going on or whatever, but there's not much I'm going to be doing now, for that part of it. Um, and she was really cool about it and just said, why don't we just reschedule it? Why don't you just take the day, be with that family, help them with whatever they need, and then we'll do this, whenever we can put it back on. Which is what we did, and she ended up having the surgery and everything went great. But really kind of I thought kind of a cool moment between patient and me in terms of kind of just working together to figure out the best thing to do. Of course, desaturation, being on ECMO are both absolutely terrible things, right? So less than, if you desat to under 70, 80, you get at least organ threatening desaturation, life threatening desaturation. And ECMO, if you go on ECMO, your odds of doing well have gone dramatically down. And so there's a bunch of different studies looking at, it really depends on why you're on the ECMO, what happened, and comorbidities. But some of these big ones say 40 to 50% that you'll get out of the hospital, that admission, without dying if you're on ECMO. So not a good situation. There's a question in the comments that says, "What did you find most challenging? The desaturation, the EVD not working." That's a good question. The neurosurgery folks were dealing with the EVD the whole time. Um, and so frustrating that it was kind of on and off, not working, honestly. Clearly, the desaturation event was the kind of craziest time because we, at that point, still don't know what's going on with his brain, whether he'll wake up, all those things. So that was pretty challenging throughout. He gets a CT, of course, as soon as he's stable enough to get in. He's got these massive main stem clots that you can see here. He remains in the cardiac ICU on ECMO. He's on ECMO for about 2 weeks, and he ends up kind of waking up, opens his eyes, moving his uppers and his lowers. Kind of remarkably, he's like the same person, and he's intact, and he's like 5 out of 5. And on 2-4, he gets a thrombectomy because they basically said he's never going to come off ECMO because he can't. He's trying to push against his clot. It's not working. And then 4 or 5 days after that, gets extubated, comes off ECMO, and then about 20 days after that, he's back walking in the hospital, and he discharges, which is kind of one of the craziest things I've ever seen. So one of the crazy things about all of this is as he was waking up and coming to and stuff, and we're realizing he's just normal, which we did not expect. Um, he did have a few funny things to say where, one time, apparently he had some crazy dreams during that time. And but but one of the first times he was awake, he goes, "Man, you guys aren't going to believe this. I had some crazy dreams." And I still remember us all sitting there like looking at each other like, you might want to hear what happened to you first. Like, I don't know if those were dreams, but he did have some he did have some crazy dreams that were not exactly what happened to him. Um, so somehow he managed to do fine brain wise out of all that. He went to rehab after that. He ends up coming back a week later. He's in the ED because he's leaking CSF out of his skin, out of one of the drain holes now, and so that gets oversewn. We discussed with him like you probably need a shunt. He doesn't love that idea at that point. Comes back, so he leaves. Comes back 20 days later, leaking from a different drain hole, which is kind of crazy. Or I think this one was from the incision actually. And we oversewed it and admitted him. I said, look, you have to get a shunt. Like this is not going to stop. And so a couple days later, he gets a shunt by neurosurgery. And since then, he's been actually doing really well. And so that worked and stopped things. Um, Here he is now. I just saw him this, what, 2 weeks ago. He's intact. He's ambulating. He's his normal self, which is kind of crazy. And still like the world's nicest guy, very grateful. Kind of went through this just harrowing journey that no one should have to go through. So, what was the point of all this? I don't know. I think if you're doing an en-bloc spondylectomy, you have to prepare for complications, and hopefully they're way less than this. This is just kind of a crazy. Last time I saw him a few weeks ago, I asked him if he was writing a book because this is like just the craziest thing for one person to go through and still be like now walking and alive and being normal. And I think you have to prepare for complications. The patient has to be prepared for complications. The family has to be. And I think when you have complications, it's okay to be human and be yourself with the family. And not only with that family, but in this case, the other family that I was then supposed to be operating on next. Um, I think most people kind of understand that and would rather just people be themselves and be honest. And um, uh, yeah, really the story of a remarkable and resilient patient and family more than anything else. Still no local recurrence or anything like that, and like I said, now back ambulatory and walking around. And I think with that, that is the end. So thank you for listening. This is us at Global Spine last week in Istanbul, taking in some Turkish basketball here with my son. But happy to answer any questions if there are any more in the chat as well. All right. Well, certainly reach out if there are any questions or comments moving forward. And thank you again for joining tonight.